Let's do carotid duplex ultrasound interpretation. So this is the most common vascular test in our lab. About half the tests are carotids. The indications are listed here. Probably should have put them in order of most common. I would say most common one is going to be screening for atherosclerosis. 2 would be presence of other vascular disease, mostly coronary disease. So if somebody's got coronary artery disease, you might want to know, do they have carotid disease? After that, it would be possible TIA and then BRUI. And then these are all other potential indications: retinal infarct, pulsatile tinnitus, syncope, subclavian steal. The structures that are imaged, we got the common carotid here, external carotids, internal carotids, right vertebral artery, the innominate, and then the left subclavian, left vertebral. So these are the imaged portions. The conditions that we'll see, obviously atherosclerotic stenosis, atherosclerotic plaque, subclavian steal, fistulas, fibromuscular dysplasia, once a year or so dissection in the arterial system that's imaged, mobile plaque, it's another doozy. I see it occasionally, maybe once a year. Incidental findings: thyroid nodules, thyromegaly, lymph nodes in the neck, a jugular DVT, rarely. These thyroid nodules, they come up all the time, and how to deal with them is doctor specific. So each doctor has their own approach. There are guidelines about that in the ultrasound literature. So now I'm going to get back to this. We're going to do the meat of the lecture, the velocity criteria for stenosis. And we'll start with the internal carotid and carotid bulb. When the artery is normal and there's no plaque, generally the velocities are like this: peak systolic velocity less than 180, end diastolic velocity less than 40, and the peak systolic ratio of the ICA to the distal common carotid is less than 2 to 1. So those are generally normal. Normal is defined by there's no plaque present. Mild disease, which is set at less than 50%, there's plaque present. So you see plaque, and then the velocities are less than 180, less than 40, ratios less than 2 to 1. And you'll see these are the same. So unlike in aortic stenosis, when there's a velocity cutoff between mild aortic stenosis and no aortic stenosis, which I think now is 2.8 meters per second. That changes from year to year, but anyway, there's a cutoff between normal and mild. For aortic stenosis, there is no such cutoff in vascular land. So that's a little confusing for those of us who know echo. And in this instance, mild disease, you see some plaque, and then you have these velocity parameters. Moderate, which is defined as 50 to 69% stenosis. There's plaque present, and then the peak systolic velocity is in this range, and diastolic velocity in this range, and the ratio is here. And if 2 of the 3 are moderate, that means it's moderate. However, if, say, 1 is moderate and 2 are mild, then mild wins. So that comes up all the time, where only 2 of the 3 of a given parameter, of a given set of parameters, is in support of the degree of stenosis, and you just pick one with 2. And then lastly, severe stenosis greater than 70%. There's plaque present, obviously, and then these are the parameters: 230, 100, 4 to 1. When a vessel is near occluded, it's just trickle flow. It's like you put your thumb over the faucet and there's only a little bit of water dripping out. There's no velocity, so that flow dynamic is not governed by jet physiology, and the velocity criteria don't apply. Of course, there are other arteries. So for these, I personally use the peripheral arterial disease cutoffs, which is a different set of numbers. And this would be for the common carotid, subclavian, vertebral, and external carotid arteries. This is just how I do it. It helps to have some way to judge how bad a blockage is. Some doctors will just say there is plaque present and won't try to qualify it. So this is a touch controversial, but anyway, this is how I do it. In terms of testing, they won't test things that are controversial or unclear, so I doubt this would be tested. Anyway, so normal is defined as no plaque, and then these numbers, less than 200 centimeters a second for peak systolic velocity, and a ratio less than 2 to 1. There are only two parameters for these peripheral arterial criteria. Mild disease, there's plaque present, and these are the velocity parameters, less than 200 centimeters per second, less than 2 to 1. Again, these are the same. So there is no velocity cutoff to define the difference between normal and mild disease. Moderate disease, you'll notice the percentage is a little different, 50 to 74%. Stenosis, that's just how it is in the world of vascular right now. And the velocity criteria, peak systolic, 2 meters per second to 200 centimeters per second to 399 centimeters per second, and the ratio 2 to 1 to 3.9 to 1. And then severe would be greater than 75%, and these are numbers greater than or equal to 400 centimeters per second, greater than or equal to 4 to 1 ratio. Of course, there's only two parameters, so plenty of times it's like you got this one and you got this one. And there's no systematic way to decide if this would be a moderate or severe stenosis. Basically, I just pick whichever one I think it is in that setting. This topic will come up on the RPVI exam, although in practical terms, the tech takes it takes care of all this, and that's differentiating internal and external carotid artery, which can be tricky because they can be similar caliber. The external carotid has branches in the neck, so if you see a branch coming off it, that's an external carotid artery. That'll be tested for sure. And then the other means of telling the difference between the two is the temporal tap. So if you tap the temporal artery while you're doing the spectral Doppler on the external carotid, the person is tap, 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 tap. It shows up as a transmitted wave. If this were being done in the internal carotid, they would tap and there would be no transmitted pressure wave. So that's a way to tell the difference between those two arteries. That'll be tested. And we'll just go through the study sequence here. Things start on the right in vascular land, so they will image, the tech will image the proximal, mid, distal, common carotid and the bulb, and then go back and put color on each of these segments and then do a pulse wave of each of those. Then they'll do demonstrate the external carotid artery, then they'll do a color of it and a pulse wave, then they'll do the internal carotid, do a color and of the segment, they'll do image and then a color and then a spectral Doppler, then the mid and then the distal. Then they'll go and do the vertebral artery on the right, and they'll look at the segment and then put color on it and pulse wave it, or do the spectral Doppler, I should say, use the vascular terminology. And then lastly on the right side, they'll look at the right subclavian artery. They generally can't see this here, the proximal innominate, and this is where blockage happens, right where vessels come off of their origin. And so the test really can't directly see that blockage, typically. So after they do all that stuff on the right, then obviously they do the same thing on the left. So that's the sequence of the study. That's some carotid ultrasound reading basics. Next lecture will be, we'll go through some studies. See you soon.